Hey guys, it's Medicosa's Perfectionalis, where medicine makes perfect sense. I am super duper excited today because we will present some really challenging cases in nephrology and biochemistry, the science that studies your kidneys as well as the chemistry of life. The video is brought to you by TrueLearn Qbank, which is not for the faint of heart. Let's get started. I hope you've watched my previous videos on cardiovascular and respiratory cases. You'll find it in my vignettes playlist. I'll also leave the link in the description box below this video. TrueLearn literally has thousands of vignettes with answers, explanations, menu summary tables, and integration with Picmonic. Indeed, you can subscribe to TrueLearn and Picmonic together in a singular transaction. Use the link in the description box to get $25 off. So without further ado, let's get started. Here is the first question. Please pause and try to answer it yourself. We have a 26-year-old woman brought to the emergency department by her spouse because of progressive weakness and confusion. The husband said that she recently had a cold and has since developed polyuria and polydipsia. There is lethargy and altered mental status, some low-grade fever, and tachycardia. Respiration 8 per minute. Blood pressure is low. Mucous membranes are dry and the urine has strong fruity odor. And let's look at the labs. Sodium is at the lower limit of normal. Potassium is okay. Chloride okay. Bicarb is very low. Let me give you a hint. When bicarbonate is low, odds are we have high-anion-gap metabolic acidosis. But let's not jump into conclusion. Glucose is very high. Serum creatinine in a female should be less than 1.1, so that's on the edge. Arterial blood pH is low and bicarbonate is normal. I hope by now, since we have the fruity odor, the hyperglycemia, the low pH, and the low bicarbonate, that you recognize that this is diabetic ketoacidosis, one of the causes of high anion-gap metabolic acidosis. Are we sure that the anion gap is high? Let's check. Give me the cations on one side minus the anions. Alright, this is my bicarbonate and my chloride. What's my sodium here? 135. And what's my bicarbonate? 12. How about serum chloride? That will be 100. Therefore, my anion gap is 135 minus 112. So the anion gap here is 23 milliequivalents per liter. Is this normal, high, or low? Of course, this is high. The normal anion gap should be between 6 and 12. So we have high anion gap, and since the pH is low, it's acidosis. And since bicarbonate is low, it's metabolic acidosis. So, would you go with A or would you choose C? Both of them have a metabolic acidosis component. Many students will say, look at the carbon dioxide here. Carbon dioxide is normal, which means there is no lung issue, so I will go with A. Big mistake. They got you, baby. Please remember this equation. The pH of the arterial blood is proportional to the serum bicarbonate over the PaCO2. What happened here? Well, we have a metabolic acidosis. So bicarbonate went down, and that's why pH decreases. That's what you call a metabolic acidosis. Therefore, what should be the normal compensation from your normal lungs? It's the golden rule. Do unto others what you want them do unto you. If the numerator has decreased, then the compensation should be to decrease the denominator so that this can cancel this and pH returns back to normal. Now here is the $64,000 question. Did the lung lower my carbon dioxide? The answer is no. The lung did not change the carbon dioxide whatsoever. Is this normal? No, that's not normal. That's a disease. Carbon dioxide here is higher than I expected because I expected to be low. Let's say 32. Instead, it's higher than expected. What do you call it when the carbon dioxide is higher than expected? Since carbon dioxide is an acid because it will combine with water and before you know it, it will give me carbonic acid. Therefore, this is also respiratory acidosis. So the correct answer is C.
Is there another way to do this?
Yes, indeed. If the primary disorder is metabolic acidosis, which it is because this lady had diabetic ketoacidosis, then the expected compensation can be estimated via the Winter's formula. It has many versions in different textbooks, but let's stick with this one. The expected carbon dioxide from normal pulmonary compensation should equal 1.5 multiplied by the measured bicarbonate, which was 12, and then you add 8 plus or minus 2. If you do the math, the expected carbon dioxide should equal 26 millimeters of mercury plus or minus 2. Was the carbon dioxide 26? No, it was 40. Oh, 40? It was higher than expected. When the carbon dioxide, the acid, is higher than expected, we have another respiratory acidosis. So this patient had both metabolic acidosis and respiratory acidosis, which makes the correct answer C. What a beautiful question. And to belabor this point, because it's worth belaboring, look at her respiratory rate. It is low. When I am hypoventilating, I'm retaining the carbon dioxide in my body. And carbon dioxide is an acid, adding another acidosis. I mean, how would you explain the very low pH right here? It is so low because we have a metabolic acidosis and a respiratory acidosis. Question number 2, please pause and try to answer it yourself. We have a 2-year-old boy coming to the office with hematuria. Adopted from China, so we have no idea what the family history is. Sensory neural hearing loss. The hematuria has been there for about 5 weeks, and this happened after an upper respiratory tract infection. Let's look at the labs. Sodium is normal, potassium is fine, blood urea nitrogen is on the upper limit or the upper edge of normal. Creatinine is high for sure. This means the kidney is in trouble. We have proteins in the urine, but not so much. But we have many red blood cells in the urine, and this explains the hematuria. This proves that this is true hematuria, not something pseudo, not like a pigment from eating too much beet, not hemoglobinuria or myoglobinuria. This is true hematuria. Next, the serum level of complement proteins C3 and C4, C stands for complement, of course, are normal. Which of the following is the most likely cause of the patient's symptoms? Is it A, B, C, D, E, F, G, or H? Step number 1. This is hematuria. The problem here mainly is red blood cells in the urine. Proteins are there, but red blood cells are the big culprit here. So between nephrotic syndrome and nephritic syndrome, which one would you go with? Nephritic syndrome. Let's try to recall the causes of nephritic syndrome. It could be acute post-streptococcal glomerulonephritis, could be rapidly progressive glomerulonephritis, could be IgA nephropathy or Alport syndrome. None of them have sensory neural hearing loss except Alport syndrome. Alport syndrome is a genetic disease. That's why the question was trying to hide the family history. So what's the problem in Alport syndrome? The problem is in the basement membrane of my glomeruli. And the basement membrane, i.e. the floor of the epithelium, has what type of collagen? Remember, type 4 is in the floor. So the correct answer here is A. Now let's try to review the incorrect answers. Ischemia of the renal papillae. This is renal papillary necrosis. We can see this in sickle cell disease. We can see this in diabetes. And we can see this in analgesic nephropathy. If I'm taking too much aspirin, too many non-steroidal anti-inflammatory drugs, or too much acetaminophen for a long period of time. None of this is present here. How about mesangial deposition of IgA? That will be IgA nephropathy, which does not cause sensory neural hearing loss. How about mesangial deposition of immune complexes? That's also IgA. Remember my mnemonic. IgA nephropathy, mesangial deposit. Next, mutation of WT1 tumor suppressor gene. That will give me Wilms tumor. If the kid had Wilms tumor, we will see a mass on abdominal examination. How about the presence of C3 nephritic factor? That will make it type 2 membranoproliferative glomerulonephritis, which has hypocomplementemia. I do not see hypocomplementemia here. Instead, I see normal serum levels of these complement proteins. What else can lead to hypocomplementemia? If you say lupus, you're absolutely correct. Next, how about T-cell mediated injury to the podocytes? That could be minimal change disease, but that will be more nephrotic and not nephritic. I will not see blood in the urine in minimal change disease. Vesico-ureteral reflux will not give me sensory neural deafness. Do you remember Alport syndrome? Yup, it was a triad of nephritic syndrome, blood in the urine, sensory neural hearing loss, and cataracts. It runs in families usually inherited in an X-linked recessive fashion. And which collagen is there? Well, remember type 4 is in the floor. Type 4 collagen is in the basement membrane, also in the lens because the lens has a singular layer of epithelium sitting on top of a basement membrane. On the exam, type 4 collagen is defective or abnormal in Alport syndrome and targeted by autoantibodies in Goodpasture syndrome, both of which will give me nephritic syndrome. This lovely table is from TrueLearn. After you answer many of these cases in the explanation, they have lovely tables. And often you will see Picmonics, actual videos embedded in the explanation under the question. Question number 3, please pause. Let's see, 77-year-old man coming to the office. We have angina, underwent what? Coronary angiography via femoral approach. A stent was placed in an artery. He has hypertension, hyperlipidemia, and type 2 diabetes. He's a smoker, or he was a smoker, and look at that, heavy smoker. BUN is high, creatinine is high, poor kidney function. But this is a recent development because before the cath, his serum creatinine was fine, which means this procedure for some reason triggered the kidney injury. So we biopsied the kidney and we found this. What do you think is going on? Look, here is the artery, the femoral artery that we poked with the catheter. This patient had hyperlipidemia, hypertension, diabetes, smoker, etc. Of course, he had atherosclerosis. As you poke with your catheter, you can dislodge some of that lipid into the bloodstream. And this lipid will give me an embolus. And this embolus can go to any organ. In this case, it went to the kidneys and destroyed them. What's the name of the plaque? What's the name of that fat, the gunk in the wall? Atheroma. When the atheroma is embolized, what would you call that? Atheroembolic disease. By the way, if this same phenomenon happened to my foot instead of my kidney, it's called blue toe syndrome.
But why is your toe blue?
Because of ischemia. Because the atheroembolus will block the arteries in my leg and decrease the blood supply to my toe. Anytime I have atherosclerosis or fibromuscular dysplasia, my arteries will be narrow. I'll hear a bruit on physical exam. Angiography is the diagnostic test of choice. All of these diseases are about narrow arteries. Atherosclerosis, and then we dislodged an embolus. The embolus blocked the renal artery. The kidney is toast. So the answer here is A. Question number 4. Please pause. We have a 40-year-old homeless man coming to the emergency department, unresponsive, tachycardia, dry mucous membranes, bicarbonate is low, BUN and creatinine are high. What do you think is going on? First, we need to make a deal. Anytime they give you sodium and chloride and bicarbonate, you need to calculate the anion gap without being asked. So let's do it. Give me the positives on one side, that's my sodium, minus the anions, the negative ions, on the other side. So what's the sodium here? 140. Minus, what's my bicarbonate, please? 18. How about the chloride? Chloride here is 101. The anion gap is 21. Is this normal? No, it is high. So we have a case of high anion gap metabolic acidosis. And given the fact that this patient is an alcoholic, homeless person, what do you think is going on? What do you think the cause is? Out of my mud piles acronym, it's probably one of the alcohols like methanol, ethylene glycol, etc. And what do we do for that? To inhibit the metabolism of methanol, we can give a medication that inhibits the alcohol dehydrogenase so that the alcohol is not metabolized to the toxic and metabolic products. So the answer here is fomepizole. Question number 5, please pause. Let's go. Worsening vision, especially at night. We call this nyctalopia or night blindness. Moreover, we have dry, scaly skin. I already know what's going on. And then they give you this picture. What do you see in this picture? I want you to look at the shape of this cornea. What do you call that? Keratoconus. Kerato means cornea. Conus means like a cone. It is as subtle as a brick through the window. So when I have nyctalopia and dry scaly skin and keratoconus, what do you think is going on? If you say vitamin A deficiency, you're absolutely correct. But it's not in the choices. So which of the following is a risk factor that can lead to vitamin A deficiency? The answer here is choice A, celiac disease. Because if I have celiac disease, I have a problem in my gut, which means I cannot absorb fat or fat-soluble vitamins, including vitamins A, D, E, and K.
But hey, medicosis, why not isotretinoin?
Isotretinoin is literally vitamin A. How come vitamin A is a risk factor for vitamin A deficiency? It's impossible. C'est impossible. Question number 6. Please pause. We're studying a novel agent that interferes with several reactions in metabolism. We discovered that when the drug is added, the concentration of NADPH produced by the cell is decreased, which means that this drug interferes with an enzyme that uses which of the following substrates? I know what you did. You said
NADPH is part of the hexose monophosphate shunt or the pentose shunt, and the pentose shunt is important to make ribose and ribulose compounds, so some of you chose D, others chose E. Incorrect and incorrect. Read the question carefully. They're asking about the substrate that's binding to this enzyme. First, what enzyme is this? What's the key enzyme in the hexose monophosphate shunt? The key rate-limiting enzyme here is glucose 6-phosphate dehydrogenase, G6PD. It's the G6PD that gives me 6-phosphogluconate, and by doing so, NADP will become NADPH. The experimenter gave a medication that inhibits G6PD, which means no more NADPH, so the level of NADPH goes down. Now, they did not ask about the name of the enzyme, they did not ask about the name of the products, they asked about the name of the substrate, what binds to the enzyme before the reaction takes place. And the answer here is glucose 6-phosphate. And that's why I absolutely adore this TrueLearn Qbank. Question 7. Please read and pause. So apparently ovarian cancer and endometrial cancer run in the family. Which other cancer is also likely? Now let me show you this doozy table from TrueLearn. If it was ovarian cancer and breast cancer, this will be the BRCA mutation, which literally means breast cancer. If it was breast and endometrial, that will be Cowden syndrome. But remember, the question had ovarian and endometrial. Which one has the ovarian and endometrial? The answer is Lynch syndrome, aka hereditary non-polyposis colorectal cancer with the infamous microsatellite instability. So if I have Lynch syndrome, I can get endometrial cancer, ovarian cancer, skin cancer, and colorectal cancer. It's called hereditary non-polyposis colorectal cancer. So the correct answer here is B. So we just answered 7 questions from TrueLearn. Question is, how many of them have you gotten right? If you say 7, we need to talk because you can't handle the truth.
6 out of 7 is superb. 4 to 5, pretty good. Well, 3 or less, I do not want to hurt your feelings, but it's an honorable occupation. There is no shame at all. So whether you're preparing for USMLE or COMLEX, or the boards of physician assistants, or even if you are already a practicing anesthesiologist, OBGYN, specialist, surgeon, family doctor, etc., TrueLearn has a Qbank for you. They literally have thousands of questions. All of them have answers and explanations. You can create a Qbank block based on the difficulty from 1 to 10. You choose your grade. You can even create a block on a specific topic like tuberculosis, just tuberculosis. Many of the explanations include summary tables and picmonics. Just like here, for example, this was a question about Campylobacter jejuni, and in the explanation under the question, you can see this picmonic. Click on it and a video will play in the explanation section under the question. And you can purchase TrueLearn and picmonic in a singular subscription. Use my link in the description box to get a $25 discount. And as you know, I will never recommend a product that I have not tried before. Not only I've tried TrueLearn, I have finished more than 11% of the entire Qbank. I have went over 311 questions at least, and I'm so proud of myself. When you see a question with this picmonic symbol, it means that the explanation contains a video from picmonic, which is an animated medical mnemonic. So what are you waiting for? You can try TrueLearn right now for free. Use discount code medicosis or click on the link in the description box to take your education to the next level. Thank you so much for watching, and thank you TrueLearn for sponsoring this video. Subscribe for more and check out my playlist called Vignettes to watch my previous video on cardiovascular and pulmonary questions. As always, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.